This will be an overview of knee replacement surgery, including why to get your knee replaced, what's involved beforehand, the day of surgery, and what to expect afterwards, as well as the risks involved and the implant materials that we use. I hope this helps. So the first question you have to answer is why have the surgery in the first place? Obviously the number one reason is pain. You have to have x-rays to demonstrate that the bones are grinding together, since arthritis is defined as the surface covering cartilage wearing down, thus making the bones come together, generating pain and often swelling. If your quality of life is affected such that the things that keep you happy you're no longer able to do, or if you can't do basic function at work. Also, if you are waking up at night, that can be real problematic for people and often drives them towards joint replacement surgery. If you find that you are self-medicating on a daily basis with non-steroidal anti-inflammatories such as ibuprofen, Aleve, those in the long term can beat up your stomach and kidneys, so you don't want to be on those chronically. And obviously if you're having to take narcotics, that's not a good thing to do in the long term, and so you want to be off of those as soon as you can. How do you prepare for knee replacement surgery? The best thing you can do ahead of time is try and get as strong as possible in preparation. That can be difficult when the knee hurts, but the stronger you are going in, the easier it is coming out the other side. So as much low impact activity as you can tolerate is often a good thing. You also want to make sure that you're not taking any narcotics before surgery. That can be difficult for some, but I find that people are happiest after surgery if they've completely stopped those beforehand. In terms of weight, I encourage my patients to get their BMI below 38 if they are obese, as that will make rehab much easier and you're going to be healthier overall, so it makes everything better. If I'm using computer guidance for the surgery, then about a month before surgery you'll have an MRI that gives me an accurate three-dimensional map of your knee joint, which then I size and place the implants on the computer prior to surgery, and there is a 3D printing of the jigs that I use on the knee joint during surgery. What type of risks do you have to worry about when you get your knee replaced? Well, number one is blood clots. I give everyone a blood thinner for at least 2 weeks after surgery, which is usually high-dose aspirin, to help minimize that risk. The number one way you avoid them is to walk. The sooner you're moving, the better. So that really emphasizes the importance of getting going the same day of surgery if at all possible. We also worry about stiffness after knee replacement. We don't usually see this after hip replacement, but for some reason knees can get stiff. If you're not able to bend to at least 90 degrees at the knee joint within 4 weeks of surgery, then I often recommend manipulation under anesthesia, which is a way of saying you go to sleep for about a minute or two at most, and the surgeon will bend the knee to break up the scar tissue that's built up in there to try and maximize your range of motion. If you wait too long to try and manipulate it, 2 months, 3 months, or longer, then it's much more difficult to try and regain that range of motion. We also worry about infection, probably about 1.5 to 2% risk. You get antibiotics through your IV during the surgery and for 24 hours to reduce that risk. That risk is approximately tripled in the diabetic population, so we are more vigilant in terms of that group. The skin nerves that feed sensation to the front of your knee go from the inside of the knee to the outside of the knee, so many people will have numbness on the outer side of the incision. Sometimes that shrinks down and becomes minimal within a year after surgery, but for some that can be permanent. It doesn't affect your strength, but it is something to keep in mind. Another risk we worry about is continued pain after surgery. For some reason, knee replacement isn't always a home run, and we see about 10 to 12% of people who have pain that we can't explain. If there is continued pain, there is a workup that typically gets done, including bone scan to look for loosening of the implant, which can happen with some people, or infection, which you always want to make sure is not part of the picture. Here I'm showing you a model of a knee joint. It's the outside and the inner side of the knee. You can see how the knee flexes and straightens out through a cam rolling mechanism. If I turn the kneecap out, you can see the blue, which indicates the surface cartilage. When that wears off, that's how we define arthritis. If I flex the knee, show you the surface cartilage on the thigh bone, and then the meniscus cartilage, which is in between the bones, and the blue again indicates surface cartilage on the shin bone underneath the meniscus. When we resurface the thigh bone and shin bone, these are the implants we use. You can see that the thigh bone implant is curved and the shin bone has a flat surface, and they link together with a post in the middle on many designs. And this is how the new knee will straighten out and bend. The implants are bonded to the bone with a bone grout called methyl methacrylate. What should you expect the day of surgery? Well, nothing to eat or drink after midnight the night before. Just like with any surgery, the anesthesiologist wants your stomach to be empty. You will come to the hospital, you get the gown, you get an IV in your arm, and then I will come ask you which side we're doing surgery on. This is common practice these days. This is to help confirm the proper side of surgery. After you tell me which side we're doing, then I take a marker and I put my initials on that knee. The anesthesiologist will then talk to you about how they're going to keep you comfortable during the surgery. The majority of patients these days do what's called a spinal anesthetic, where the anesthesiologist spends about 5 minutes in the operating room before surgery, numbing up your back and injecting an anesthetic that numbs up your legs for about 3 hours. That way you can either be asleep or just twilight sort of napping on and off during surgery while you're perfectly comfortable. Another way of numbing up the leg is an adductor canal block, which I've been using for a few years now. And that's another numbing medicine injection on the inner thigh under ultrasound guidance that can be done by the anesthesiologist. And that provides pain relief over the front of the knee for up to 24 hours after surgery without causing any weakness in the leg. So I have found those to be quite helpful. Surgery itself takes about 45 minutes. After surgery, you go to the recovery room where they make sure your pain is controlled and your heart and lungs are functioning properly. Then you go out to your room, and that's where the physical therapist meets up with you for the first time. If you're not feeling too dizzy or nauseous, then we get you up and try and stand up that first day. Just depends on how you're feeling. Sometimes in the hospital we use what's called a continuous passive motion or CPM machine to get the knee moving, where it gradually, slowly flexes your knee and straightens it back out while you're sitting in bed. There have been studies that show that's not really necessary or beneficial in the long term, but it does give you some exercises to get moving early on. After you demonstrate that you're stable, getting in and out of bed, in and out of the bathroom, and up and down the hallways with your walking device, either the walker or crutches or a cane, then we let you get out of the hospital. When you go home, you'll have home health physical therapy and nursing for the first 7 to 10 days typically. And then once you're able to get into a car and go to outpatient physical therapy, they will start up with you. That can go as long as 3 months with less frequency in terms of the weekly visits as you go along. And it all depends on how your motion is, how your strength is, and how you're feeling. The incision site has dissolving stitches and skin glue on top with a waterproof dressing, so it's okay to get in the shower on day 1. People generally see improvements for up to 12 months after surgery, but the first 3 months is the lion's share of getting back to your daily activities. I usually see about 2 or 3 weeks before people want to drive. A big question that comes up is when you can return to certain activities that you enjoy. Some people as early as 3 months will get back into cycling and swimming. It can take more like 5-6 months or longer before you're doing higher impact activities such as skiing. So it really depends on the person and what your fitness level is going in, and that really helps to determine how quickly you bounce back and whether or not you can get back to the things that you really enjoy.